It's my real pleasure to introduce you to Professor Andrea Rockall from the Imperial College in London. And Andrea's really has driven the field of AI in cancer forward with all the excellent work she's doing. So she's going to teach us about using imaging data sets for machine learning, reality, and challenges.
Thank you very much. Well, it's a little bit of a personal journey, and I feel a little bit like the fall guy, because when I moved to Imperial College in 2012, I was asked by my academic boss to start this thing called machine learning with the guys at South Kensington, and I'd never heard of machine learning. So I didn't really know what I was doing, to be frank, and I made a lot of mistakes. But I had a lot of big ideas, and I think I've learned from trying to move the big ideas across into reality. Hopefully I'll be able to show you some of the ways we got on at Imperial and where we're going now. And my decision was that we were going to do machine learning in whole body MRI. Now, that was the first mistake, because I had no idea how tough that was going to be. So I'm going to discuss a little bit why I decided to make that decision and what drives a choice of a machine learning subject. Then I'm going to show you some of the challenges that we had to face up to. I'm going to talk very briefly about incorporating some biological data and generalizability, and then some challenges that we want to try and face and plan for in clinical translation. So why did we go for this whole body MRI? What was the decision? Well, we wanted to, obviously all of us want to improve patient care with early detection of disease, improving patient pathway, patient treatment planning, as well as detection of response. And it just happened that at the time I was part of an investigator group in the Streamline study run by Stuart Taylor in the UK. And what they were doing was doing a prospective collection of whole body MRI in patients with colon and lung cancer. So we were going to have a database coming our way of 500 to 600 whole body MRIs. Now, whole body MRI is pretty tough to report. And so I thought, okay, fine, that's a great machine learning project. So that was my first mistake. And the other machine learning study that I started when I was working at the Royal Marsden was another clinical unmet need, multiple myeloma, which Christina Messieu, who's here in the room, she's a world-class researcher in multiple myeloma research. And here we had a tool which was fantastic. So this is a patient with multiple myeloma. This is the accompanying MRI scan. And the whole body MRI has become the tool of choice to analyze and detect myeloma. In fact, to such an extent that NICE have issued guidelines that this is the preferable tool, and they issued these guidelines in 2016, just as I arrived at the Royal Marsden. So it seemed to me, with the largest database of whole body MRI in myeloma, possibly anywhere, that this was again a super machine learning opportunity, because machine learning is a way that we can translate some of these more challenging imaging tools into clinical practice. So here, just to give you an example from the myeloma, we have a patient with a high burden disease, a low burden disease. It could be quite difficult if you weren't an expert to pick up that low burden of disease. And also, sometimes we don't have a secretory output in myeloma, so the imaging becomes an absolute critical part of deciding whether to start treatment or not. So, why hasn't this important technology translated into clinical practice? We have whole body MRI technology available. We can see that it has, certainly in myeloma, a nice guideline. And now the Streamline study has been published, which showed better detection rates for the tumor and probably better patient pathways. So why hasn't this translated into clinical practice? Well, part of the problem, of course, is that these studies have a huge amount of image data, multiple sequences. You've got T1 with Dixon, T2s, you've got your ADC, your diffusions, etc. And it's really tough for radiologists to report this in a timely way. And rushing through the reporting pile, there's a risk that also we lose accuracy. So we have increasing complexity. And also in some cases, here is a study that we did over at Imperial in healthy volunteers in a whole body MRI. And here we have a comparison with three patients with myeloma. And you can see again that depending on the age of the patient and the type of myeloma presented in the bone marrow, it could be quite difficult to recognize the healthy bone marrow compared to the diseased bone marrow. So we have a really good unmet clinical need here. So I think the first thing is to really identify an unmet clinical need that machine learning could help us to overcome. I don't think we want to go down the route of using machine learning for the sake of it. And we have to, of course, formulate a hypothesis. So, of course, we started off with these great ideas. Okay, we're going to have, we've got an unmet clinical need. We're going to have a hypothesis-driven study. And we're going to do a power calculation, work out how much data we need. But, of course, that's the perfect situation. I mean, what you face in real life is not a perfect situation. We do a beautiful flow diagram. We're going to have phase 1, healthy volunteers, phase 2, training, phase 3, validation. And that's when you're putting in for your grant application. And it all goes fine when you're doing your healthy volunteers. You've got a single scanner in a single center. The patients are pretty fit. They haven't got hip replacements. And you can do really beautiful training for segmentation of the healthy volunteers. And then you can test this on larger data sets to see the, how wonderful your machine learning work is going. And you think, okay, this is just super. And we can measure the multi-organ segmentation in multiple subjects, and we can look at the DICE coefficients, and we can see where the machine learning is doing well and where it's more limited. And this was in a relatively small number of subjects, as you can see. In the Malamar study, we're segmenting out all of the bone marrow, and of course we have other challenges related to extra osseous sites of disease, and these are just clinical challenges that we're facing, but not the real technical challenges that we have problems with. So the big problem is when you're devising one of these studies, you go through powering the study, you've got your statistical analysis, and the statistician says you need X amount of data in order to prove this much benefit. But the problem is, do you actually have enough data to actually answer the hypothesis? And so, we only have limited data in whole body MRI. It's not like mammography where we have hundreds of thousands of cases. So you can go and do your whole study plan, and when it comes down to these statistics, you're suddenly left with a problem. We can see here that in phase 1, where we're doing the training here, this is in the myeloma study, we actually have only 200 cases allocated, because what happened was, when the statistician got hold of the study, they said, well, actually, in order to prove and validate your findings, you're actually going to need 353 cases in the second phase. So we knew we only had a certain database to start with, so we had to lose data from the phase 1 training. Now, that's not ideal, and that's not what anybody would want to happen. But when it comes down to the statistician, you've got to do what they say. And so we came across this type of problem where you might ideally want to have, say, 1,000 cases in your phase 1 training, but we just didn't have that number of cases available in the data set. So we have to try and mitigate some of these challenges. This was a challenge that we faced in the first study, the machine learning in body oncology, where we're looking at the streamlined study data. Initially, we thought that we could use other data sets. So this is a whole body MRI data set that we used from a myeloma study. We also had another data set available from a prostate cancer study. But when it came down to it, the imaging used for the different studies was too different. It was not harmonized sufficiently. And so we ended up only being able to use the streamlined data, which at least had similar sequences. So you end up, when you start off, you have a large number of cases that you think are available to you, and this gets eroded and eroded by various issues that you face along the way. You get a large variability in cases, variability in sequences, and then even when you get the cases that have the right sequences, etc., you then end up having the data transferred, and then you have corrupt data, and so you end up having smaller data sets than you planned for. The other issue is this beautiful, beautiful slide from Daniel Ruckert and Ben Glocker that I work with. In the lab, of course, you have a lot of harmonized data, but in real life, we have quite a lot of variability in the patients that we scan. And this is from the Malabo study. We can see here just a subset of patients with different heights, different sizes. We can see that actually something that doesn't trouble us as radiologists, this one's missing the head, but that caused a lot of problems with the machine learning. And we've had to do a lot of work to try and harmonize this data set that came from 15 or 16 different hospitals coming into this prospectively collected trial. Nonetheless, the data is really quite variable. So we've had to do a lot of work with data harmonization and work in progress using transfer learning, intensity normalization, all things that we never anticipated at all. So we have challenges in planning the study in the first outset. You know, how much data was certainly when I started writing this grant back in 2012, 2013, I didn't really have any idea how much data would be needed to adequately train to do the task that we wanted, which was detection of disease. Really didn't know, and there wasn't any data out there to make any assumptions. And the next thing was, now we know how harmonized does the data need to be. I mean, we found that it needs to be reasonably harmonized so that the task is realistic, that we can actually achieve some form of learning. So we needed some basic sequences from the series, and we had to not use two studies that we had hoped to use in the study, in the overall machine learning study, because the data sets and the sequences were just too different. Nonetheless, we still want to allow some generalizability, so we want the same sequences, but from different centers, different machines, different manufacturers, so that we get some differences that we can get a good algorithm, but not that are so disparate that we can't actually train anything. The other thing that I've learned along the way is that it's really important to understand about the allocation of the cases into training, validation sets, and test sets. And this is not such an easy process, because you might start with 700 scans, but then you might discover that, for example, a large number of the scans are, for example, one patient might have 7 or 8 scans. So you can't distribute those from training into test and validation, because the machine would be seeing the same patient over and over again. So you need to be sure that you have a clean training set that is completely separate from the held out validation set. And that takes a lot of effort, as Theo will attest to, who's working on the Malamar study. The other issue is we want to avoid bias. So how do you allocate cases into the training, validation, et cetera? And certainly in the Malabo study, we got the whole data set in, and then we gave it over to a statistician who then stratified the cases into patients with or without metastases, and then did a randomization of allocation into training and validation. So we need to be sure that we're not biasing selection into the training and validation sets, and I think that's important. The problem is you have to wait till the whole data set is in, and that you have some form of knowledge about the data set as to what type of disease is present, so that you can have a fair balance. And then the other problem is that once you randomize it, as we discovered, sometimes the cases that are randomized into one set or the other are not usable, so you end up not having the perfect data set that you wanted. This is this fantastic study that just was published recently in Radiology last week. And, I was really interested to look at the huge work that they did in, separating out all these numbers of cases into the training set, the validation, and the test set. And the test set, of course, they had to be sure that this was in breast cancer, and they had to be sure that the test set truly reflected patients with disease and without disease. And I was very impressed. This is definitely worth a read if you're trying to set up any large training study, and it's a very impressive paper. I just want to talk briefly about generalizability. So we did a very small study here, which just illustrates, I think, a really important point that we need to think about. And this is just a body composition study, and we know in ovarian cancer, in which I work, that sarcopenia is quite relevant in terms of the patient's outcome. And we can see here that with healthy patients, it's really relatively straightforward learning task to segment out the musculature. So that was a good task. If we could just learn to do that automatically, then all our patients with ovarian cancer coming through Imperial could have their sarcopenia done. The problem is, this is another challenge. This is now a real patient with ovarian cancer, a large amount of ascites. We've got peritoneal disease. And so training the algorithm to pick up the muscle versus the peritoneal disease and the ascites became really tough. But anyway, we started off, this is just another patient with a big ovarian cyst, and that can be a real challenge for training. But just to discuss the generalizability with this task, the first thing we wanted to do was to say, okay, we want to measure the muscle at the L3 level. So the first thing we wanted to automate was just to be sure that all of the scans that come through, we could confidently identify the L3 level. And so, of course, we don't just use the patients from the ovarian cancer. We took patients from all different data sets, from different studies, TCGA, different scanners, different centers. And we can see here that we've used CT scans with all different slice thicknesses. And also, again, we can see some have heads, some have shoulders, some don't. So we've used different image heights. So we've tried to use a whole variety of images, and we've trained it on over 1,000 data sets from Hammersmith Hospital and from different publicly available data sets. And we can get the detection for the L3 level very, very, very well and very tight. We also had to think about anatomic variation, and I think that's important. Patients can have transitional spine, so we said, okay, how will we build in if the patient has transitional spine? So we built in a confidence map in case the algorithm thinks that there might be 2 levels. And I actually think that's nice to have a confidence map rather than just always giving the single map, and that's what we do for ourselves. And I think to give an interpretation on the machine learning output that conveys the level of confidence in findings is important. And so we tried to do that. And I think generalizability in some tasks is really achievable, and we should be working towards that. I want to talk about a few challenges that we came across in the actual segmentation tasks as we went through the Streamline Malibu study. One of the things I think, particularly having just finished a huge amount of segmentation for one phase of the study, is labeling noise. How good is our ground truth? And especially with MRI, where we perhaps don't have such well-defined tumors, we were trying to, these weren't lung cancers on CT scan. Here we have bowel cancer, which can be quite difficult to know where the borders are. We had diffusion, ADC, T2, but sometimes people were uncertain what the border of the tumor was. And for example, another big question mark is, in the patients with myeloma, do we have diffuse disease, or is it indeed healthy marrow? And these are difficult, challenging questions. And when we're trying to label the scans, we want to do the best we can, but we don't always know if our label is 100% truthful. We have difficulties with margins. What do we do with artifacts? Of course, this is MRI. We might have hip replacements. We have to keep those in so that the interpretation is generalizable. But these are all difficult issues. When we have multiple readers, who do we take, if there's some differences, who do we take as the correct ground truth? Do we take a mean? These are all not fully answered questions, and these are challenges for us as radiologists. I think the labeling contour does vary depending on the task that you want to undertake, and I know that Jayshree was mentioning this earlier. A boundary box approach might help with a very large data set if it's only a detection task, for example, but in a radiomic task, you want to be sure that your segmentation is very tight to the tumor so that you don't train incorrectly on extraneous tissue. And I think moving towards labels based on patient outcomes is going to be really important, but you need much larger data sets to do that. This is just to show you some work we did on looking at the safety and repeatability and reproducibility of segmentations that we used in our radiomics paper we just published recently. And what we did was we did an erosion and a dilation task of the original ovarian mass segmentations, and then we looked at how the erosion or dilation affected the radiomic prognostic vector that we were measuring. And we could actually see that by making the segmentation smaller, we developed more differences in the radiomic prognostic vector than if we actually expanded the original segmentation. So we can look at segmentation changes by these type of studies to see what works and what we might be careful about. So just lastly, what about the challenge of translating these findings into clinical practice, and how can we robustly validate? So in the Streamline study where we finished making the algorithm, how do we then test how that algorithm performs? So we could do that in a lab setting. We could get the radiologist into a lab, a quiet room, no telephones going off, and we could see how they perform with or without the machine learning algorithm. But what about trying to put the patient into a clinical environment? So here we have the output in the streamlined study. We've got 3 patients with a colorectal cancer. We have the diffusion here, the original manual segmentation here. And here we've actually tested it then on a machine learning output, and you can see here the probability map of the cancer. And we've superimposed that onto the whole body MRI, and we've put that into a PACS reading platform. So essentially, we can see here that we've changed that into this so that the radiologist can scroll up and down with the T2, the diffusion, and the ADC, and we have the probability map popping up and in and out based on the probability of finding cancer, rather like a PET CT. And so what we've decided to do is actually to try and test that in the reading room rather than in a lab setting, to actually try and emulate what we do in clinical practice. And I think also we need to validate these across institutions, and we've already talked about distributed computation. So, for example, some of the tools that we have developed, we will now be sending out to other centers. So the sensitive data, which is the patient DICOM data, can stay at the collaborating center. We send out the algorithm. Actually, they're going to send some to us. And then we share the results and see how we're performing and whether we need to work on the algorithms once again. In that way, data access can be regulated by the institution. It can be kept behind the firewall, although we do have some tensions developing between the request for open source data by the research funders. For example, Cancer Research UK would like all of the data to go open source once the studies have been completed. And we also have this whole issue about public and patient acceptance of sharing data. So I'm just going to finish up. I know I'm out of time. I'm just going to finish up with the last bit where I think we really need to work on the validation. And I think we need to think about the validation a little bit like the drug development phases. And if we have the phases of drug development over here, we can imagine what we would need to do in a machine learning phases, going from small, does it work? Can it work in a larger set of patients? Can we move it across into multiple centers and test accuracy? And then how do we survey this in a post-marketing setting? And if we look at the segmentation task here for the muscles, you can say, okay, phase 1, we take normal healthy volunteers. It's 1 center, it's 1 scanner. Yes, we can segment. Then we have to move that over to lots of patients. Can we make it work with different sizes of the slice thickness, different heights of scanning? Okay, yes, we can get it to work. Now, can we design a good study to undertake using a distributed computation model? Will it work in lots of centers? And does it actually link to the patient's outcome or biological data? And especially, can we test it in a real-life setting where we can know it's going to work when it comes into our hands in the radiology reporting room? FDA have approved some tools without going through this whole process, and I think that's okay if they're triage tools, but we do have to be aware as radiologists what's happened. If they've skipped those stages, then we need to be very careful about auditing the results. So those are my lessons learned from a lot of problems that I've faced over the last few years. You have to start with a reasonably harmonized data set that's of sufficient size so that you can actually achieve the task at hand. Data sets are never going to be as big as you first thought. Confidence in segmentation may need to be communicated in the training data because we don't always have full confidence in what we're segmenting, even as hard as we try. I think careful planning of the training, validation, and test sets is really important so that we avoid bias in our training. And I think the validation needs to be robust, it needs to be realistic, and we need to test generalizability of the tools across institutions. Thank you very much.